Good afternoon, good evening, everyone. I'd like to thank you again for joining us here at the Dana-Farber Cancer Institute for PHEN's Managing Survivorship that we host each month here. This is going to be a very interesting topic. What we wanted to do is talk about testosterone, because you hear about this all the time. But before we move on to the presentation, I'd like to take a few minutes, a few seconds to thank our sponsors who, without their help and their assistance, we wouldn't be able to bring you these interesting topics each month. So I'd like to thank Amgen, Bayer, our host institution, the Dana-Farber Cancer Institute, Exelixis, Johnson & Johnson, Merck, Novartis, and Pfizer organizations. So we have men here, and we're going to first spend time just to talk about this topic, and I'm going to bring our slides up now. So testosterone recovery, I mean, that's the primary topic, is what happens, what should you know about recovery after ADT? And really, why does this matter? So what I wanted to say is that this is a point that I want everyone to understand. Monitoring testosterone before, right, during, and after treatments help patients and their care teams better understand recovery and make informed decisions. And it's very interesting because whether you're online or here, how often have you spoken with your healthcare team and asked them about testing your testosterone? So we're going to break it up into 2 20-minute sessions. One, I'll present, answer questions for 20 minutes, and then we'll have, you've already taken the pre-survey, and we'll have a post-survey to kind of get a feel how effective we are and how comfortable, what did you learn from this discussion? So tonight's focus, I want you to understand what ADT does, know why baseline testosterone matters, learn why monitoring before, during, and after therapy can support survivorship planning, and discuss what optics adds as a real-world evidence. Now, again, I want everybody to understand this is not going to be treated as clinical information. And if you have clinical questions or there's private clinical questions that you have, we would suggest that you refer those to your care team. But we want you to understand that this is for educational purposes. First thing, testosterone recovery. Testosterone recovery is not, testosterone is not just a number. You need to be able to monitor it. And I have someone here. It's better on. Okay. How many times have you seen your doctor or your healthcare provider and they talked about testosterone to you? And if, raise your hands. They talk to you about testosterone when you first, what about, I have one person that has, but then when did they talk about your testosterone? When you started taking an ADT?
Before and during.
Okay, that's good. Because that's when you're supposed to talk about it, at the beginning. Now, there are 5 questions they're going to help guide our discussions. What I mentioned before, what does ADT do to testosterone? Why can lower testosterone affect the quality of life? What does recovery mean after the treatment stops? What does optics add about relugolix in the real world patient care? And what should a patient ask their care team? Remember, we're not trying to remember the numbers. What we're trying to do is understand them. So what we're talking about here, and I'll move this hopefully out of the way. I can't. You might have to come up. I can't get this out of the way. The ADT 101. So lowering testosterone to control cancer growth. Androgen deprivation therapy. So do you understand what androgen deprivation therapy means? Do you understand what that means?
Explain.
Hmm?
Explain.
Okay, I'll explain it. Androgen deprivation therapy, we're talking about lowers testosterone or blocks the androgen. So testosterone is an androgen. And so when you lower testosterone, in most cases, it helps slow and control prostate cancer because prostate cancer depends on androgens, in this case, testosterone. Now, you can use this form of treatment after radiation, after recurrence, or if you have advanced metastatic prostate cancer. Now, the plan duration depends on the cancer setting and your treatment goals. So remember, doing ADT, the goal is effective suppression after a planned course. Okay, so now when we start talking about testosterone has effects on prostate cancer, it's just not on the prostate cancers itself, but it has an effect on the total body. So yes, it can slow up the growth, but some men notice fatigue, right? Lower stamina, hot flashes, changes in mood or sleep, lower sexual interest, erectile changes, loss of muscle mass and strength, and weight changes. And these also, there's some bone concerns. So when testosterone is lowered, the whole person can feel the change, not just the cancer. So when we're looking at recovery, why recovery matters after a planned course of ADT. If ADT is meant to be temporary, many patients ask a very human question. When will I feel more myself again? That question matters because energy, mood, sexual health, intimacy, muscle strength, stamina, confidence, bone health, cardiovascular health, metabolic health, and the overall quality of life are all part of survivorship. So, when will I feel like myself again is a very important question. So, now recovery varies, and it's not the same for every individual. Every man may behave differently. Remember, this recovery of your testosterone, so those who have 30 days left in treatment, is going to be individual. And it's going to be influenced by the testosterone level before you started receiving ADT. The length of time you're on therapy, because there's some are 6 months, a year, 2 years. So it may influence how quickly it goes up. And it also depends on the baseline. A man generally should not expect recovery to a number higher than he started. So is that clear? And you need to have a baseline. So some of you who started ADT had a baseline PSA and a baseline testosterone. Okay. So this is just a simple little image, but this is what you need to have. So when you are getting your PSA tested, you also should ask and make sure that you're getting your testosterone tested. And so you can start tracking that the same. Because what this does, it shows where the patient, where you started before you had ADT. It helps to set realistic expectations for recovery after treatment and helps interpret symptoms and the quality of life changes. And then it creates a cleaner survivorship record for future visits.
Excuse me,
Yes,
doctor, is that the same test to test on NADT, or are they separate?
it's a separate test because you're going to have PSA and then the hormone testosterone will be tested individually. Okay. So remember, what was your testosterone before you begin treatment? And I think that those people online, those people here at the Dana-Farber, it's going to be important for you to track and understand those two variables, especially in survivorship. Now, during ADT, you confirm suppression. That's a reason to look at your testosterone, and you're monitoring your health. And that's why it's so important. It's not a one-off, or you're just going to get the baseline. There's a little bit more that you need. So during ADT, you want to answer 3 different questions. First, is the cancer marker responding? PSA is the cancer marker, and you're following that over time. Second, is the testosterone suppressed? Because we know that testosterone testing helps confirm that ADT is doing what it is intended to do. And third, if you're tolerating the treatment, right? The care team should hear about fatigue, about mood changes, sexual health, hot flashes, bone health, any cardiovascular related problems, medication issues. All this information is important, and this is the information that you're going to have to be able to collect. And this is why it's important to keep an accurate account of what your testosterone level. So, a practical question. What testosterone levels are we aiming for during ADT? And how often will it be checked? So is that something that your healthcare provider was able to provide you when they had their discussion?
Yeah, and they took my testosterone levels before, the PSA before, and then they waited, then 3 months in, they took it again to make sure that it was at 0. And then they started the radiation.
Okay. So, and they explained to you why they were taking this at these time points. And so that's the type of communication that you're going to have with your clinician, your healthcare team. And they will, but you're going to have to ask and you have to keep track. So just want to make sure people understand, if your PSA rises, progression is suspected, testosterone helps the clinician understand whether the disease is progressing despite cutting down the testosterone levels, or whether suppression was it wasn't enough treatment. Okay? So now, if we're understanding that we want to confirm suppression, we want to monitor your health, how are you feeling on all these different areas? Now, after ADT stops. Recovery is a trend. And so that means what that is that recovery is not going to be automatic. The moment you get off, it's not going to be automatic. So it's not a single day change. It's going to be a gradual change. And what you'll see is after your treatment, and some of you here are beginning on the end of their treatment. And once you take the last pill, it's not going to bring your testosterone level the next day back up to normal. So there's going to be a gradual increase. Now I want to move on to just another topic. We want to look closer at ADTs. And there's an ADT, relugolix. And what's interesting, a lot of people may be taking leuprolide, and that's an injection. But this is a oral ADT that's FDA approved and used for the treatment of prostate cancer. Now, yeah, this is a big fancy word, gonadotropin releasing hormone receptor antagonist. That's what it does. So there are two general categories. You can be an antagonist and compete and block testosterone's role, or you could be an agonist. And so there are two different categories. This relugolix is antagonist. Now, what's interesting about it is it has been reported to have a faster recovery time back to your baseline. But let's look at this a little bit more. We know it's FDA approved for advanced prostate cancer. And it's one option, and it depends on what you're looking for, your treatment plan. And what you want to recognize that it is a pill, and daily adherence matters. But you should speak to your care team about medications, missed doses, side effects, and any problem taking this medicine consistently. That's going to be important. Now, I want to talk about just a simple clinical trial. And it's the HERO clinical trial. And this is what provided the information so the FDA would approve relugolix. So what they saw was medical castration. So let's just put it this way: your testosterone levels dropped significantly down, and you had 96% what they call medical castration from day 29 through week 48. And then what was interesting, that at 55% achieved greater than 280 nanograms per deciliter, but that's your baseline. So when the testosterone comes back, you reach a baseline fairly quickly. And this is why this clinical trial is so important. And there were some points that we want to bring up about the clinical trial, is that 97% of the patients achieved and maintained medical castration 29 days through 48 weeks. On this clinical trial, they looked at 137 patients who did not receive additional ADT for at least 90 days after stopping. And this study, 55% achieved testosterone levels above normal, the normal limit. Okay? And then majority of people within 90 days returned back to your baseline level. So remember what we said before. We said that your baseline levels are your reference point. And that's where the direction that you're going. You're not going to go back higher, but at least you go back to where you started before you received the treatment.
And if you don't get back to where you started, what is it?
Hmm?
And if you don't get back to where you started, what does that mean?
Well, in that case, there's some people that don't get back, but you should be approaching your baseline with this medication in this clinical trial. So the hero was a clinical trial, but then, and that was a good transition, because what we want to move into is, I don't think that people recognize that there's something called a registry. It's different than a clinical trial, because a clinical trial is tightly regulated, and there's a control group that doesn't treat it, receive it, and there's a group that receives it. I'm just keeping it very general. But in a registry, this is more like real world evidence. This is what happens in the real world. So why does this matter? So clinical trials answer controlled research questions, right? Registries show what happens in everyday practice. Optics was a prospective, multi-center, observational, and it's still ongoing. Now, it follows the patient's treatments with relugolix in the US as a monotherapy, meaning a single treatment, or with other treatments that you're receiving at that time, which is systemic treatments. So in this registry so far, they have close to 1,000, 999. It's like, might as well say 1,000 patients enrolled. 844 had started monotherapy, because in your case, monotherapy, you only had one ADT that you were taking. And then 155 had the ADT plus some other treatments. Now, and then they were looking at patient-reported quality of life, the adherence, the safety of testosterone levels, PSA outcomes. All this is being tracked at one time. And I just want to stress that optics, OPTYX, is an observational study and does not have the randomized comparing arm control versus treated versus untreated. So that's something that is reflecting of what's going on in the real world. So if we look at this clinical trial, and this is why we thought that this is very important, is because we need to understand if the majority of people are taking ADTs, we have to understand how they impact us. How do they impact the quality of life? What type of ADT treatment would you like to have? So if we look at just the interim, how is this clinical trial, how is this registry doing at this time? So what happens, what we see is greater than 90%. So when you were on the treatment, greater than 90% receive levels of testosterone levels were lower than 50 nanograms per deciliter. So the concept of castration or absence of testosterone, lower levels that prevent prostate cancer growth. So, and they did this by the 6 month. And then of that population, 66% of those had reached these levels below 20. So what they're seeing here is that this oral medication, ADT, is very successful inside this 6 month window. Now, what was interesting is that when they took them off of it, within 6 months, they were reaching testosterone levels above the baseline. And that's what you want to have, because some of the other ADTs and those that are agonists, that means they compete with testosterone for the same site and can influence even testosterone levels, may take a longer time for you to recover your testosterone level. So that's very important, especially for people who've received radiation treatment and they may have started on ADT for just a short period of time. You want to have access to something where you have a faster recovery of your testosterone levels, because the higher the testosterone levels, the quality, there's a change, or you're back at the normal quality of life that you're accustomed to. I put it that way. So when we talk about recovery means in daily life, right? This is important. You want to get back to your normal life. Now, there was a question here. Once you're off the ADT, you may not always get back to the exact number, but your objective is to get to that number as best as you possibly can. And so patients may hope to see changes in energy, physical stamina, mood, motivation, sexual interest, muscle strength, and sometimes you may not. But you want to be able to keep track of these, and you want to monitor how you're feeling, your quality of life, along with your testosterone levels. And that's kind of what we're trying to do. How are you feeling? Are you still having fatigue? Are you low mood? Sexual health concerns, weaknesses, hot flashes. How do you feel in relationship to your testosterone level? And so these are some key points. Some key points that you're going to monitor: energy and physical stamina, mood, sleep, and motivation, sexual interest, intimacy, conversation. What about muscle strength, confidence in just doing a daily activity, your weight, metabolic health, cardiovascular health, bone health? All of these play a role.
I have all those issues.
You have all those issues? Are you still receiving ADT? So we'll talk about that. So we want to make, and that's why Managing Survivorship is here. That's why we have these sessions, because this is something that, if you think about it, we haven't really talked about testosterone. And it's a rarity that you hear. I mean, we spoke about it, but in this detail. Because are they linking measuring your testosterone levels with the quality of life and continually monitoring? Because the majority of people keep track of their PSAs, but they don't keep track of their testosterone levels, especially if they're on ADT and short-term or long-term treatment. So here's some questions that I want you to kind of think about bringing to your care team. How long do I need ADT? And what is the goal? Okay. Second, was my baseline testosterone checked before treatment? And in your case, it was. What testosterone level are we aiming for during ADT? Was that explained?
Yeah.
And what did they suggest?
I was thinking 0, and it did get to 0. So
Okay.
yeah.
So it did get, okay. So
Yeah, after 3 months.
after 3 months. So you're trying to get below 50 and get below 20,
Right.
but you got to 20. You got to 0.
I got it down
To 0. Okay. When should testosterone be checked after last dose? Okay. Because that's going to be coming up. What symptoms should you report, even if your PSA is stable? See? Because there's still that, because we're focusing on the PSA being low or 0, and our testosterone level above or close to where it was before. But the question, are you still having these symptoms? Because remember, monitoring helps us understand your treatment plan.
So what is it that you, what will build your numbers back up to close to where they were supposed to be?
Well, during this recovery period, removal of the ADT, in this case, we were talking about this oral medication, this antagonist. There's been reports that it's a faster recovery time than what you'll see when we start talking about the injections.
Okay, so you're saying that the pill is faster than the injection? After the pill,
I'm saying the type of treatment, in this case, the relugolix is a pill.
right,
It's oral. In this case,
that your testosterone recover faster than if you had the injection. That's what you're saying?
I'm saying from the study, from the optics registry, there appears to be a faster recovery time. That you reach within 6 months, we're reaching your baseline or close to your baseline level.
So you're saying the injection, there's a longer recovery time than the pill.
So I'm saying from the registry,
Okay, from the registry,
I can talk about this medication has a recovery time that's faster, but I don't want to jump out and just say it's faster than the injections, but from the data that they're publishing, the registry is suggesting and that there was a faster recovery time than with some of the,
compared to two.
well, no, we'll put it this way. So, but if you're looking at the time period in this registry, this group of people, we gain baseline levels faster than people who were normally using that other form of treatment, the injectable one. So that's what I'm kind of comfortable saying.
But even though you, in the pill form, even though you finished it, it stays in your system still for so many days before it leaves the system and you.
Yes. But it's tighter because you normally take it on a daily basis versus you're getting an injection, which could have a response, a continued response for 30 to 90 days, depending on your injection. And so the pill, and plus that the pill form that we're talking about is an antagonist, and it's been reported to have, it like takes the brakes off or allows the recovery to be faster than the reports when we start looking at like Lupron or something like that, the injectable form. So what I wanted to do is let's spend some time, and we want to open conversation now. Now, you're welcome to ask a question, share a brief reflection in this, and I want you feel comfortable to ask these questions so you're better prepared when you go in and you speak with your care team. And so I don't need to hear private details, and because those I would prefer to, if you're not comfortable with those, don't talk, because we're on, don't convey those because we're on their virtual audience. And then I would redirect those certain questions that you may have back to your care team.
I have a question.
Okay.
What if your testosterone level drop after treatment?
So if your testosterone level drops after treatment and it hasn't recovered. The question is, what form of ADT is the person who's asking the question have? Do they have an oral ADT or do they have an injection? That's because what we're finding is the majority of people with, and when we go back to the optics registry, or if we go back to the HERO clinical trial, we see that Orgovyx or Relagolix, the same, that there is the majority of people are within 6 months are back to their normal levels. And I have a question, there's one, it said, before you started ADT, is there something that you wanted to know ahead of time that you wish you would have, would you want to know if there is a oral form? Because a lot of people didn't know. So case in point, where did you learn about Relagolix and to talk to your doctor about?
Well, I had the Orgovyx. Is that the same thing?
Yeah, Orgovyx, yes.
Yeah. Reading and talking to you.
Okay, so reading and then the PHEN meeting. Okay. Now, so when we started talking about when you spoke with your healthcare provider, who talked to you about quality of life?
The oncologist.
Hmm?
The oncologist.
The oncologist?
Yes.
So when they talk to you about quality of life, what were they saying that some of the things that you may experience?
The hot flashes.
The hot flashes. What else? I mean, closer to the mic. You can.
Oh, I'm sorry. So the hot flashes.
Right.
The low libido. Fatigue.
Right.
Mood swings.
Mhm.
And then I'm saying that you may have them, but this ain't the possibility you may have those. So some of them I didn't have, but some I did. And pretty much, pretty much, your energy, that type of stuff. So
So if you didn't mind, what's your story? So
I had a recurrence.
You had a recurrence.
Yeah.
Okay.
And it was low.
And it's low.
It was low.
Right.
But he wanted to treat it aggressively. So we decided to go the aggressive approach and do the testosterone with the radiation.
Okay. So in your case, did you start your androgen ADT before or during radiation or
Before.
before?
And at least 3 months before, and they wanted to see to make sure that it was working the way it's supposed to work. So that means based on where my testosterone was, they took the baseline first. Then 3 months later, they wanted, I wouldn't say 0, but it was less than 10 nano, whatever it is, but it was less than 10.
Yeah, less than 10.
And that's where you wanted to be. So from there, after 3 months, then they started the radiation treatment.
Yeah. Okay. And so where are you now in your?
So today was my last radiation treatment, and I still got 28, 29 pills to take for my the androgen, the ADT to be finished.
So you're taking
pills, pills to be finished. Another 20.
So Orgovyx.
Once that's done, so I still got to finish that first because it was a 6-month treatment, and 8 weeks of radiation. So
8 weeks of radiation.
Yeah.
So you feel comfortable that the topics that we are talking about here were discussed in the planning, and you received it during treatment, and today, and I wish the audience will give him a hand because he just finished his last day of radiation. So Jerry, another question?
Yes. Are there any statistics showing how many people return to their baseline testosterone levels after stopping testosterone therapy?
Yeah, if we go to the registry, and so that registry we talked about, and that's the optics. And I have that we're looking at within 6 months, just with, we can talk about this clinical trial because I thought it was this registry because I thought it was important, is that when the Relugolix or the Orgovix was discontinued, and they were monitoring the testosterone levels, 42% recovered above 280. Okay. So above that is approaching or in that normal testosterone range. And that can vary, obviously, but they're saying 42% within 6 months. But then and so more and more recovery. So it was a very successful recovery period in a 6-month period. So that's what the registry was talking about. And that's what we're going on. Now, this registry is going to be collecting more and more information over the next 2 years, but that's what they're seeing, how quickly you recover after the ADT, or in this case, this oral ADT was given and removed, discontinued. So anyone here received the injection ADT? You did? So, can you tell us your experience?
Like I said,
Can you speak with the mic? Speak in the mic.
I experienced all those effects that you were referring to earlier.
Mm-hmm. So, are you on ADT right now?
No.
So, how long were you on ADT?
I think I went for a year.
Mm-hmm.
And then I think I came off, I think it was November 2025 or somewhere around there.
Okay, so you were on it for a year and you received the injectable form.
Yeah, I had a pill also, but I forget the name of the pill that I was taking along.
So was that bacalutamide? Is that from?
Yeah,
but you weren't taking the Relugolix. So the one that no. So let me ask you a question. How long ago did you stop?
I think that's when I stopped in 2025.
In 2025, you stopped?
Yeah.
So are we talking about over a year?
No, November 2025.
So you stopped, what are we talking about, 8 months ago?
Something like that.
But you're still experiencing?
I would say so but then again, I'm not sure I would say so, but then again, I'm not even sure if it's because of that. Sluggishness, weakness, tired.
Now, is it something, is this something that you would have felt that, did your doctor talk to you about another option for the ADT, or they just gave you the injection?
I don't even recall if you talk about another.
Are they?
You just initially I was having the injection. When they realized it was going back up, then we went to the injection and a tablet. But not a tablet, but I think it was either 2 or 4 tablets I was supposed to be taking while I was doing the injection.
Okay. So it doesn't sound like you were taking the Relugolix.
No.
So you in this case, you are November, December, and we're in the 7th month. So you're 9 months off of this treatment.
something like that, yeah.
Yeah. But you're still, how was your energy?
Well, I'm not even sure if I could attribute my energy to that. Cause, I'm not even sure if I could attribute to that. Because, I realized in, October last year, I start feeling like sluggish and weak and whatnot. But as far as the sexual feelings, that was nowhere near, that was nowhere around the place.
Right.
And
So you don't feel you recovered?
no, but right now and around that time, it was oh shoot, no, in 2023, November 2023 or January, somewhere around there, my testosterone level was like a 3 or something like that. And since I stopped the treatment, is only now back up to 190.
So your testosterone has only made it up to 190?
Yeah.
Do you recall what it was before you started? Was it lower than 190?
Initially, before I started, it used to be like somewhere around 600-700 or something like that.
Yeah. So what we're seeing here is that your testosterone level before you started treatment was 600 or 700, and now it hasn't made it return back to above 200, or even made it back to what one would consider to be normal range.
Yeah, that's what I'm saying.
And have you spoken with your healthcare provider about this, or?
No, because I figure that was expected after the treatment. I wasn't sure that or I didn't know that I was supposed to get back to close to where it was initially after the treatment, 6 months after the treatment or a year after the treatment or what. I'm supposed to be seeing him I think it sometime later this month, I think it is. So I can probably question it. And at that time he will be doing some blood work, because he usually does the testosterone and the PSA at the same time.
At the same time. So he is testing the testosterone.
Yeah. So he will probably, when I get the blood work, then I go and see him. I could ask him, is that the normal time it usually takes, or if it's moving too slow or what?
Right.
Because if I remember correctly, when this thing first came up and my testosterone was up, if I'm not mistaken, somewhere close to 700 or something like that. So I didn't even know it was supposed to get it back, because it was always said that cancer feeds on the testosterone. So I'm thinking if my testosterone stayed down, then the cancer won't have anything to feed on. So I figure maybe that's the way it's supposed to be, but I don't know.
Okay.
Is there a correlation between the time that you're on ADT? So I'm thinking that if you're on ADT for a year as opposed to 6 months, is that recovery time equivalent to the length of time that you're on it as opposed to the shorter time? So if you're on it for 6 months and you're saying, okay, well, maybe in 6 months it comes back to close to, and then if you're on it a year, is that equivalent? How does that work?
What they're saying is just to kind of be careful, is that it depends on what form of ADT. I mean, yes, that you have. So was it the injectable one, or was it the one that we were talking about? You use Orgovix, but Relagolix, the same, that one. And from the HERO study, clinical trial, and from the optics registry, recovery time once they're off it with the Relagolix were, above 40% of the people were back at 6 months. But I don't think that there's been a heads up comparisons between Lupron, but if you look at the registries, we have an example of a person who took the injectable one, the agonist, which had a positive effect on the receptor, a positive form of treatment versus a negative form of treatment. And he hasn't recovered back to normal yet, but he's been off for 9 months. Everyone's different, but one would have expected that you would have recovered back to above just what considered to be the baseline normal, and which hasn't happened as of yet. And so we'll be able to go offline, or after this, we can identify questions that you can ask your doc, your healthcare provider, the next time you visit. But to go back to your question again, everyone's different, and it's not going to go back to normal the next day. But the trend is, over time, you should reach back over that 280 level into a normal range.
Was that based on a 6-month ADT registry, or was that a year?
I'm talking about the registry.
The registry was for how long?
That was 6 months.
Oh, 6 months.
Yeah. At 6 months, it was about 44% at 6 months. So, Jerry, did you have a question, or what were your thoughts? Okay, so I'm going to answer some more questions, but we want to put the poll up, and we want you to answer these, because this is a complicated topic, because we're not stopping here, because prostate cancer is also linked. There's a relationship with prostate cancer and cardiovascular. And this is a very important drug that we want to talk about, because men who are at high risk for cardiovascular disease should be considered, or have the discussion about talking to their doctor, if they're going to start ADT, that they start Relagolix. No. And that's going to be important. So we're passing out the question. So someone have a question while I can answer it while you're. Yes.
Yeah, I had a question. He raised an interesting point in that cancer testosterone was feeding the cancer. So if you bring your testosterone down, and I know you want to get it back for quality of life, but wouldn't getting it back up high means that you present another risk of getting the cancer again?
Well, it depends on, because we didn't talk about his treatment. Did you have surgery or have radiation?
Me?
Yes.
Treat the radiation.
So you had radiation.
Yeah.
So that means they targeted around the area where they suspected the treatment is.
Yeah.
And then they kill the cancer.
And then it returned.
And it never returns.
It returned.
And it returned.
In 2015.
Okay, so.
I got the first set of treatment. It's funny. I was getting a Lupron shot in 2007 up until 2010. When I, lost my libido and all that kind of stuff, and I questioned the oncologist about it. And he said, yes, that's one side effects. And I said, how come it wasn't mentioned among the other side effects on the paper? He had no answer. So I was so angry and adamant that I just stormed out of his office. And I never went back. And that's how I ended up at Dana-Farber.
And so this point,
that was 2010, and 2015, that's when I got the radiation around the area. No, that was 2010, 2011, when I got the radiation around the area. And then when it reoccurred, I got, I guess what they call seed implant or something
Right,
like
right.
that in 2015, where they put markers, something like rice grains or something like that, and feed the radiation through the tubes once
Right.
those seeds lit up in the
Right.
area in 2015. And then after that, I don't know, maybe a year or two later or some stuff, or three, somewhere around there, my PSA started going up again in 2021 when they did some scans.
So now your PSA is elevated again, or has it dropped down?
Well, it dropped, and
And so since
it has been pretty low. Actually, it hasn't really gone back up since
November,
November, really.
so this is an example where you receive treatment, and then it's almost like a treatment holiday, and they're going to be monitoring your PSA levels to make sure there's no cancerous growth. But in your case, at the time when they were treating you with the ADT, it was the injectable form, and right now it's significantly impacted the quality of life, your quality of life.
Right.
And you would have preferred, and this is why this is kind of slow and methodical discussion about testosterone and why it's important and why you should follow it, and why you need to understand that there's a different type of ADT, because not all ADTs are the same, and how important for everyone here at the Dana-Farber and everybody online to understand that there's other treatments out there, and especially if you're of African descent, you should have that discussion, because we're going to talk about ADTs and cancer and cardiovascular disease in one of our next topics. And since African American men of African descent, are at higher risk of developing cardiovascular disease, we're not saying that they're the only folks out there, but I think that there needs to be a discussion earlier on about the use of different types of ADTs, especially those that have a tendency to have a lower threshold for causing cardiovascular events. So, Jerry, where are we with our polls?
I didn't finish mine.
Okay. So, the first question, after this session, how clear is your understanding of ADT, what ADT does in prostate cancer treatment? About 50% said very clear, 42 says somewhat. After this session, how well do you understand why testosterone levels are mentioned or monitored before, during, and after ADT? 59% said very well, 38% said somewhat. After this session, how well do you understand what testosterone recovery may mean after ADT ends? Again, 59% very well, 38% said somewhat. How confident are you that you can ask your care team informed questions about testosterone monitoring, testosterone recovery, and the next steps after ADT? About 75% said they were very confident, and 25% said somewhat confident. How prepared do you feel to discuss ADT-related side effects such as changes in energy, mood, sexual health, muscle strength, or quality of life. 77% said very prepared, and this is where we want to move for you to be prepared to have this discussion. Somewhat prepared, 23%. Which topic did you understand the most in this session about testosterone recovery and survivorship? What ADT does and why testosterone matters, and that was 7%. What testosterone is monitored before, why testosterone is monitored before, during, and after, 7%. What testosterone recovery may mean after treatment, 20%. And 67% said all of the above. And that was what we considered to be important here, because this is a topic that the majority of folks don't really talk about. And this is a very important topic. Testosterone levels, testosterone recovery is very important. So, what statement best reflects what you learned today about testosterone recovery and survivorship? Testosterone recovery happens the same way for everyone, 3%. Testosterone does not need to be monitored after after treatment, 3%. Testosterone recovery can vary, and patients should ask their care team what monitoring recovery may mean to them, 90%. That's where we wanted to go. This is the start of understanding the relationship between not just monitoring your PSA, but also monitoring your testosterone and the type of ADTs that are available to you. Did this program allow adequate time for audience Q&A? 56% said yes, 41% said somewhat, 4% said no. Would you recommend the session to others? 88% said yes, 12% said somewhat. How would you rate the quality of discussion? 70% said excellent, 20% said good, and 4% said fair. Would you attend another survivorship focused session? 100%. So the fact is 100%, that means our content is something that people want to hear, and we'll try to do better next month than we did this month, because that's what our aim is to bring you topics that you haven't heard or discussed, or give you examples of patients, of men who've been treated and how they felt when they didn't have the correct information and how they felt when they had the correct information. So, how did you feel about the session pace? 85% said just right, 11% said too fast. Were you satisfied with the meeting and the presentation content? 74% said very satisfied, and 24% said satisfied. Prostate cancer patients. So let's look at who was here. 96% of the were prostate cancer patients and survivors. 96%. And we had some medical professionals that were in. So I know this is a kind of difficult topic, because I didn't want it to be like a didactics, but we wanted to start with a baseline. And I wanted to make sure everyone, whether you're online or here at the Dana-Farber, don't just ask for that PSA. Ask for that testosterone level. Know what it is. If you're being just recently diagnosed and you're in that process, you haven't began treatment, know, in addition to that PSA, know what your testosterone level is. So, gentlemen, here, caregivers here, and online, virtually, thank you again for attending PHEN's Managing Survivorship, and look forward for another interesting, thought-provoking topic in managing survivorship of prostate cancer. Thank you.